You're going to bring up the first slide, please. There you go. So thank you so much. It's great to be here. I'm a doctor, in case you can't tell from my slide here. And when I was in medical school and did my training, I got the computer bug. And this was just in the beginning of the PC revolution. And I wound up getting distracted and invented a couple of companies along the way, one of which was in the health space to help remote people in remote parts of the world, actually provide clinical medicine when they didn't have much training. I did some other things that helped do mail merge and things like that. But in those early days, the one that really took the cake was I invented what became the first computer antivirus product, and I sold it to Symantec, and it became Norton Antivirus, which obviously became a pretty big success. So I did all my, although I've got an MD PhD and did training and have residencies and all that stuff, I wound up doing most of my clinical work at night in the emergency room because I had to pay for these companies I was starting up in the IT sort of spaces. If we fast forward a little bit, about 20 years ago, 21 years ago, HIPAA came along, and when HIPAA came along, it's interesting, we all look at HIPAA today as though HIPAA was the, sort of the bane of our lives. It just drives us all crazy, right? But when HIPAA came along, doctors were actually asking for somebody to tell us what would be good enough privacy, what would be good enough security. Would somebody please help us figure this out? And most of us think that HIPAA is about privacy and security. When you actually spell it out, HIPAA, the P in HIPAA is for portability. The P is about interacting and sharing medical records and sharing information. About 5 years later, Bush was in the White House, and he had the same problem that every other president had, and that problem boiled down to the cost of health care keeps going up and up and up. And, for those of us who took a science class somewhere in our lives, did anybody take a science class somewhere in your life? For those of us who took a science class somewhere in our lives, we mostly put a bacteria on a petri dish. And that bacteria turns into 2, and then each one duplicates and turns into 4, and then it duplicates again and turns into 8, and pretty soon it fills the entire petri dish. And the only time it slows down its growth is when it runs out of food, right? Well, that's what healthcare costs are like, right? Every year it keeps going up and up. It's going up as a comparison to all money around. At some point, you consume all money, right? So the Bush White House sort of got together and said, we can only beat up the insurance companies and the pharmaceuticals so much. Isn't there something that these newfangled computers could do to help reduce the cost of health care? And so the Bush administration started the Office of the National Coordinator, and that derived from this President's Information Technology Advisory Committee, and I was privileged to be invited to come and be part of this sort of thing. This was a 2-year stint that was, this committee of ours had subpoena power and all the cool things that you get when you're hooked up with, with the big government, to go figure out if you could, the basic charge was, if we could make healthcare use of information technology something kind of close to the banking and financial world's use of information technology, what would happen? Isn't there some way we could sort of bend the cost curve a little bit somewhere? Is there something that angle might do? So this was a 2-year project, and that 2-year project led to a bunch of other things, but the short of it was that we interviewed a bunch of people. We had secret clearances. We got secret documents. We had hearings. We had testimony. We had all kinds of things. And we talked to the vendors, we talked to the payers, we talked to the providers, we talked to everybody. We got recommendations from everybody. And we got all kinds of financial and economic people to calculate things. And we wrote a report at the end of all this, and the report, I'll summarize it. It was multi-hundred pages and all that, but I can net it down to 3 things. What we said was, if healthcare's use of information technology could be somewhat close to banking and finance's use of information technology, if we could just sort of get in the same ballpark. At the time, we thought that healthcare was very advanced in technology. You could swallow a pill and video your intestines, right? But very behind in the use of information technology. So if we could get parity, what would happen? Well, one thing that would happen is everyone would be wildly healthier. They'd live longer, we'd have less downtime, less time away from work, et cetera. This is obviously called quality in our current world. So the quality would go way up. Second thing that would happen is that costs would go way down. Our report suggested that costs would go down by $70 or $80 billion a year. But right after our committee closed down, this science was applied to the National Institutes of Medicine, who applied a more rigorous economic study to this. And they thought that costs would go down by $700 billion a year. This is more cost saving than any proposal by anybody that anybody of any political party ever spent or wanted to spend or saved or wanted to save. It's well beyond any of that. So if you could only get this parity, so everybody'd be wildly healthier, costs would go wildly down, and by the way, we'd have data on everybody, and we didn't have an entirely new kind of science. But other than that, it probably isn't worth doing, right? So this was the outcome of this. Notice, and I'm going to come back to this theme a few times, the 2 criteria that are needed to make all those wonderful things happen is that people use computers pervasively and they share that information somehow, right? And I would contend, and we'll get to this, that the computer use is starting to work, but the sharing part is not. Now, you all remember somewhere in the late 90s, we had this market went off a cliff and the market crashed and the world came to an end and Bush's era was ending and he did the TARP that was $700 billion to try and save the economy. And he handed the keys off to Obama and said, good luck with this. It's going to be a bit of a challenge, I think. And everybody was looking for shovel-ready projects. Remember shovel-ready project? Well, after our committee closed, everybody was all excited about trying to figure out how we could maybe drive some actual change in healthcare. And so committees got together and built programs and built ideas and put together packages and so on. And so when Obama spent $800 billion on the ARRA, you all know this, they spent 35 or so billion of that on the HITECH Act. The HITECH Act became meaningful use and led to the drivers for us, incentives and whatnot, to try and make meaningful use of health information technology. That's where it all came from. We had lots of national coordinators that came after that. David Brailer was the first one, but Blumenthal came after, and so on and so on. So this has all grown over the years. Most of you have been part of it. Most of you tried to collect your $40,000 per clinician to try and get your bonus payments from meaningful use. Many of you started on time. If you did, you've got some $40,000 here and there because you checked the boxes. Some people got a little bit late, and therefore there's maybe another year or so to go, and you can get a little more payment this year. Starting last year and this year, you start to get penalties for all that in Medicare and otherwise. Lots of other people have jumped on the bandwagon, and now we have MIPS, which is a conglomeration. I'll talk about that in a minute. This whole idea was entirely organized around the notion of if we can use health technology and share it, we can have wonderful, great things happen. Now, of course, it didn't pan out exactly the way everybody hoped. I was one of the naysayers about how all this was going to work. And so I just wanted to give you a little jump forward to the technology trends that we are now. I call this BigSoMoClo. So the trend we're under right now, this isn't something you can go invent. This is the world around us, is driven by big data, analytics, all that, social media, mobility, and cloud computing. This is it's not one thing. It's not just about mobile computing. It's about all these things. And the reason that Uber works, or the reason that you can, pick up your phone and get navigation like that, or the reason that you can do all these cool things with your mobiles and tablets and phones and things, isn't just the mobile, it's all the other parts too, right? And BigSoMoClo gets pervasive power in cloud computing. It gets pervasive analytics that make it available to work against that pervasive power. It puts the hands of, there's more power in your pocket right now than there was on the Apollo mission that went to the moon, right? This is not even close how much power there is in your pocket compared to how much was on that spaceship. So this power winds up actually working to simplify things and make it possible to give power to the person. And so if you combine that secure, private, ubiquitous, engaged communication and the rest of this power in BigSoMoClo, you get what I'll call BigSoMoClo Care, which I'll just call Big Health to shorten it, right? This is really the same thing that we're all trying to achieve, right? We're not even close to feeling it, right? Just the opposite. Most of us hate computers. Most of us hate the EMRs. Most of us hate all this stuff going around us. Most of us hate the thousands and billions and jillions of rules and grids and check boxes and things that we need to do. But notice again that the part that's not working of this mess for us in healthcare is that communication. We really don't use these things to do much sharing of that medical information, either between each other in the groups or between groups or some of the rest. If you could do that, I'll just change the words a little bit, the power of BigSoMoClo has really moved the power of most organizations to the person. This is what we mean by disruptive technologies. When we talk about how Uber disrupted the taxi industry, it's because it put power in the individual's mind. It allowed all kinds of things to happen that move the power to the person. This same thing should put power in the clinician or the physician, right? The same thing that puts power in the patient. And the talk we just got through hearing, in fact, both of the first two talks, boiled down to the same sort of problem. It would work a whole lot better if we could only get patients together with people who know how to deal with this stuff, and we could get rid of all the crap, right? Wouldn't that be nice? So this future is laid out before us. I'm a predictor of these sorts of things, and I particularly believe that the drivers that'll drag the medicine world into the new medicine world are mostly our patients with the power of BigSoMoClo. It is just, we'll do all the things we try and do to change this world, but the patients themselves come in and say things. But they come in now with, Google searches, right? Don't I have this disease? No, you don't, but it's kind of interesting you brought that up, right? Can't I use this medicine? And so on. This all comes from the power of social media and big data and mobility and cloud and so on. Obviously, everybody hates the EMR. I can tell you that although this is Letterman didn't actually do this top 10 EMR. This is an invention of mine. But if you do, most of the problems that people think of as not about hating from the EMR, and again, I'm mostly representing the clinician, the person who's upset. 3 of the 10 things on that list boil down to, I can't get at the medical records. I can't get at the messages. I can't send a message to somebody else. We heard from our first speaker about the insurance changed and it was allocated to the doctor down the street. Wouldn't it be nice if there was something easier than picking up the phone and calling the other clerk down the street and saying, is Betty on your list? She's not on my list anymore. Does she belong to you? I got to call the other 5 primary care people in this zip code to figure out which one of us wound up with this insurance allocation, right? Well, those sorts of things, whether they're clinician to clinician or clinician to patient or clerk to clerk or clerk to clinician, these kinds of questions are everywhere, right? And unfortunately, for all kinds of reasons, we're not allowed to use simple things like text, right? Are you kidding me? We can't use text? No, that wouldn't be safe enough, right? So in our small IPA sort of world, a lot of people say, screw it, I'm going to use it anyway, right? But it turns out that that doesn't really work very well, largely because it's not integrated into the big system. It doesn't work for other people. The hospital people won't let their people do it, so you don't really have 100% capability of that sort of thing happening. So I opened up my browser a couple of days ago, and this was this picture of Biden was on the screen. So this was last week. He gave a talk at South by Southwest 10 days ago. And this wasn't my quote. This is the New York Times' quote of what he said, right? Even now, sharing of medical data is awful. That wasn't me digging through his words and figuring out how I could support my speech, right? We all hate this, right? This does not work. I'm sure your patients are not happy either, because I don't know of any patients that have only one doctor, right? If a patient has only one doctor, then they could go to the portal of the one doctor and things might be okay. But beyond the fact that everybody hates portals, nobody has one doctor. Nobody can get their data all in one place. So there's this whole movement towards personal health records. And Kevin sitting here in the front and Catherine sitting here on my team were at a conference a couple of weeks ago about some fancy new technologies, and there were 40 people in the audience, and everybody stood up and showed their wonderful, whoops, I'm going to beat it up again. Everybody was on this talking about how cool it was going to be, and let me show you my little app. The patient can do this, they can figure out how the billing is going to be, they can look at the doctor, they can make an appointment, it's going to be great. And you go up after and say, does that really work? And they say, well, no, not yet, but it's going to be great. It's going to be great, right? And when you get down to how these things are going to be great, this all works right up until the point that they've got to communicate with the doctor's EMR and figure out what the appointment is, or communicate with the hospital EMR and figure out what the lab values were, or communicate with somebody else and get back that answer so they could put it all together into the mosaic so you could actually see the answer on your app, right? Or so you could share it with the next doctor, or so any of those things can happen. Biden, of course, had a son who died of cancer, and they had to take a photograph. I mean, this is, everybody has this story, don't get me wrong. But his story was that he couldn't get the x-ray from one doctor to the next, and they wound up taking a photograph of the photograph, right? Because a patient can text, but a doctor can't, right? So the patient texted the results to the other patient at the other, to the doctor at the other end. My daughter is a horse rider. And she rides horses. Did I just say that? And she fell off the horse. I'm sure she's fallen off lots and lots of times. But she came home one day limping. And I'm a doctor. Did I already say that? And most of the medicine I've done has been in the emergency room. So I'm kind of an emergency doctor. And so my daughter came home limping. And I kind of looked at her a little bit and said, oh, you probably broke your fibula. The fibula is the little bone in the leg. And I said, if you did that in a football game, they'd probably tape it all up real tight and send you back into the game. Because if you break your fibula, it's the same as a sprain or even less than a sprain. And, nobody's going to cast it or do anything like that. Here's how it works. You're going to be better in 6 weeks if you don't treat it, and better in a month and a half if you do treat it. So either way, So I did this. My wife's a nurse. She trusts me implicitly, of course, and my kid does too. And so this happened on a Friday, and on Saturday, and the kid's still hobbling around. And I said, your mom broke her leg in the other big bone a couple of years ago. Go get that boot that she had and put it on. I'll bet it'll make things feel better. Saturday and Sunday, she hobbled around on the boot and took some Tylenol and this and that. And I went to give a speech at a big conference like this one on Sunday night. And when I landed in California, I had a text on my phone. They went to the emergency room. And my daughter texted me a picture of her broken bone, right? See, Dad, it is broken. I said, I know it was broken. I told you that 3 days ago, right? It's just that the auto ankle rules say you shouldn't be doing anything about little things like that, because all we're doing is racking up costs. So if you did care the way that we just heard, that primary doctor would do what I just did, except they'd be a little more trusting than the doctor-patient, wife-doctor-husband relationship, which isn't exactly as strong as the pure patient-doctor relationship. And they might actually believe the doctor who says, you know, it's going to work either way the same way. But anyway, she got an x-ray in the emergency room, and they got a splint, and they got some platinum pills and some serenium pills and some other pills for God knows what. And, got a $1,000 emergency room bill. And she was asked to go see the orthopedist the next day. The orthopedist was across the parking lot. The orthopedic doctor's car and my wife's car were shared. They actually scratched the car when she opened the door from that ER visit the night before. And so she went to the orthopedic office. What do you think they did? They got another x-ray. 30% of all tests that are done in one place are done again in another place because they can't get the results. Now, part of this is a payment model. Part of this is some other things. But they got another x-ray. And they said, you know, if this was a football game, they'd tape that up and send you back in the game. I kid you not, right? But I want you to come back here every 2 weeks and get another x-ray so we can follow the course of this treatment, right? They gave her a boot. The boot was exactly the same as the boot she was wearing over the weekend, except it was brand new. And they asked her to come for some other thing. What I'm getting at is that the doctor in the parking lot across the way couldn't get the x-ray from the hospital that just did it the night before because the communication part didn't work. And if the communication part did work, this thing could be easier and much more efficient. And everybody could theoretically make more money, not less. Now, back when we did the meaningful use thing, and I will admit that I was part of this, but I do say that I was the guy that kept saying, you realize this part won't work so well. Everybody was pushing for structured data. Structure, 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 structure. And I said, well, you know what? The doctor really likes the unstructured data the best. I like to know what the BUN was, or the creatinine, or the lab values, or whatever. Those are all the things that need to be structured, and the dates of the last exam, and the demographic things, and all that. It's good to have that structure. That's best. But when I see somebody that another doctor saw, getting 600 pages of stuff out of an EMR is useless, right? What I want is what I had 20 years ago, which is a concise little note that said, here's why I'm sending you this person. Please help me, because I'm worried about the following issues. We all know she's a diabetic, hypertensive, blah, 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 blah. Those are the check box on the EMR. What I don't know is why you're sending her to me, right? Or what's different about this diabetic, hypertensive person than the 40 others that you take care of. That's the nuance of medicine. And doctors and clinicians, and most of what we do is figure out the nuance, right? The main problem list is pretty straightforward. The problem that we're working through is how to solve the edge cases. What's different about your diabetic hypertensive problem today, than it was the other one? And that's all unstructured stuff. And that's a lot of stuff that's disappeared from the new EMR sort of world. If we could communicate unstructured stuff better, if we could just get a quick question off to the clerk or the doctor or somebody at the other end and say, is this because that? Is it because the medicine didn't work, or is it because the pills are pink and she doesn't like pink? What is it, right? What was the problem that underlaid this sort of thing? So I thought this whole drive towards structured was too heavy, that we really needed to balance both. The other one I thought that was bad was that everybody was putting all their energy behind putting all the health data in one place and making it available for everybody else to fetch it. if you're a data scientist, and one of the things I've been in my life is a data scientist, you can't imagine a system where you could put all patients' data and somehow make it so that only the right person could get only the right pieces of that data. It's just not feasible to imagine that. So the way we do it in a hospital is we say all the data sits in the EMR, and when it's in the EMR, every doctor will get access to it. And we just won't worry about the fact that the pediatrician could theoretically get access to the 84-year-old patient's data or whatever. We can't really set reasonable rules for who shouldn't get access to the data, so we'll just give everybody the access to the data. Then we join those hospitals together with other hospitals and doctors' offices and IPA groups and whatnot, and we say to them, oh, why don't you all belong to a health information exchange? Then everybody could get at the data of everybody in the whole community. Right? Well, of the 200 HIEs in the country, 7 of them actually work, right? But even if all of them worked, we still have the problem. I grew up in Michigan, and I currently live in the Northeast. Well, you know, some large percentage of patients don't like to stay in Michigan or the Northeast in the middle of winter, right? And they go to Florida or Arizona, right? And so those people who go to Florida, their doctor in Florida can't get the medical record from New York. And the people in New York can't get the medical record from Florida. The best HIE in the planet doesn't make that happen. It's just not something that works very well. So this pull model doesn't really work. It would, and by the way, I'm pretty sure that most of you have bosses, or most of you are bosses. And I'll bet you didn't ask your boss didn't say, give me access to everything in your hard drive, which I'll pull whenever I need it. Instead, they ask you, could you send it to me? And you say, sure. By the way, could you send me that talk that you gave a year ago on blah, blah? I thought it was great. The answer might be sure, or it might be yes, but I've got an even better one. Push has very different advantages. Push gets subtlety in if you push information to each other. So we need both push and pull, just like we need both yin and yang. And by the way, I've got a Chinese person in my family, so I had to put down yin and yang in Chinese for you down there in the bottom. So I'm going to list for you, I love prime numbers. If you ever hear me talk about numbers, you'll find that almost every number I throw out is prime, which usually means I'm lying about no, it's the exact number. There are 11 issues, and exactly 11 issues. There's not 10 or 12 because those wouldn't be prime, that cause us to have medical record sharing problems, that cause us to be in the dark ages in this world. And the first batch of them I'll call identity issues. So this is, where I'm going with this is, suppose, what would it take to actually solve this information technology problem? What would it take to make it so it actually worked for us instead of against us, right? How could we get over the chasm of making this business work for us? Because it certainly isn't working now, right? One of the issues is knowing which Dr. Smith is which. If you're going to send a record to somebody in Florida, how on earth are you going to know which Dr. Smith is which, right? And likewise, how is Dr. Smith supposed to know which patient, John Q patient is which, right? Those are big problems. Also, how do you even know the other person's a doctor, right? How do you know this, right? Well, these are all what we call identity issues. And although I, in the beginning, rattled a little bit about doing the first antivirus, in the middle there, I did a company called TrueSecure and CyberTrust, and we wound up building the biggest identity platform on the planet. We did the national ID cards for 25 countries. That's 500 million people, and figured out how to know which person is really which person. Now, in America and Australia and England and other crown countries, we are unwilling to have national ID cards. We refuse. We think of it as a privacy invasion. So, okay, we can't do that. But nobody wants to carry around a card with a chip on it that represents us anyway. Isn't there some way in this BigSoMoClo world to let us figure out who the heck the person is, the right person is, given all the BigSoMoClo data that's surrounding them, like, whatever it is, some blend of thing? And the answer is yes. And there are lots of standards in the government about strong identity. The big one is called NIST 800-63, and it boils down to figuring out who you are and letting you having access to the system. If we could organize strong identity for our doctors and our patients, all kinds of things would be better. Among them, hacking would essentially disappear. 83 or 4% of all hacking relates to stealing passwords of the person that is the bad guy is pretending to be someone else. If you knew who the person really was who's logging into your computer, that wouldn't be a problem anymore, right? Likewise, I'm trying to take care of my mother-in-law who's not, 88 years old. She can't even use a computer, right? She can't log into a patient portal, right? How does the hospital know or the doctor's office know that I'm the right delegate for her, that I'm okay, that it's okay with her for me to log in on her behalf to get at her record? Or likewise, how does the Medicare system know that the clerk in the front office is a legitimate delegate for that doctor? The Medicare office is asking for the doctor to log in, not the clerk. And name me the last time the doctor actually logged in. We all lie, right? And we lie because we have to get our jobs done. If we did decent identity, we wouldn't have to do all that. We'd actually solve all these kinds of problems. The next set of problems boil down to EMRs are proprietary systems, and they're basically fighting with each other. And when you get a bunch of vendors fighting with each other, they do a bunch of things to try and keep each other from winning in the marketplace. And in our space, these continuity of care documents, there's 9 different categories of them, and there's well over 100 different EMRs. We've got an IPA we're working with now that has 30 different EMRs just among the 300 doctors, right? Well, that's typical, right? Well, okay, I got 9 different categories of CCDs and 30 different EMR vendors, each of whom makes it a little different than the other guy. How on earth are you supposed to read that when it goes from point A to point B? So us vendor standards bodies, people said, let's make a continuity of care document architecture. That's what CCDA is. And force everybody to use the new one. That's in meaningful use 2. And this is all a little bit better, but everybody still tweaked theirs a little bit so that it would bounce off the next guy's EMR instead of flowing in nicely. So when you get a record from Epic going to Cerner or vice versa, it usually doesn't get admitted. It usually doesn't wind up in the structured part of the EMR. If you want to look up the glucose or the BUN or the A1Cs or whatever you want to look up, they don't wind up nightly in the table. They wind up at the end somewhere in something that's not really much better than a fax, and you wind up not being able to see it, and you wind up with errors, and people get sued, and bad things happen, and it's painful. So wouldn't it be nice if we could actually solve those kinds of problems? There's another reason that particularly big organizations don't like to share records with other big organizations, and this is what they call a business model problem. And it boils down to the way the standards work, the basic standard that we've been using to share EMR data with each other is called XDS or XDR. And the way that standard works is that the other entity has access to everything in the EMR. So Hospital A hates Hospital B. They don't really hate them, but they're in competition. And so, yeah, we're going to be real happy to give you everything in our EMR, right? Because in the end, that's your proprietary business information at some level. And if you gave everything in the EMR to the other hospital, then they could more easily steal your patients. So there's lots of cities. In Cleveland, the great Cleveland Clinic and University Hospitals are 4.5 blocks apart, but they cannot share data between their EMRs. It's not possible. It goes on paper. Right now, 70% of medical records go on paper or fax between organizations that are not the same. 70%. This is nuts, right? If it could just stay digital, even if it wasn't structured, it would at least be searchable, right? So let's see. Doctors can't text. Doctors can't send email. Nobody can get a digital version of a record so they can search it. Everything's working great. So there's a new protocol that's called FHIR. I spelled it there for you, F-H-I-R. And the idea of FHIR is to give people access to the record that they're supposed to have access to. So if you're a doctor and you have privileges in a particular hospital, you could theoretically use this FHIR protocol to get access to just the records that you already have the rights and privileges to. You don't get everything. You get the patients that are already your patients. Well, that's okay. So if a doctor has privileges at both Hospital A and their competitive Hospital B, the doctor can get access to both. That's what's supposed to happen. It doesn't happen, but that's what's supposed to happen. So this fire thing is kind of good if it actually comes, if we get things working. By the way, fire's been around for 3.5 years. It's required. It's not exactly written as required, but meaningful use 3, or I'll give you a little review of it here in a second, which is also part of MIPS, says you must have an API-based access for doctors. API is Application Program Interface. In the end, what they mean is you got to have fire. 1% of EMRs have fire running today. In hospitals, in small practices, it's less than that. And if you get it done by the end of the year, you get a check. Well, it'd be kind of nice to get a check, don't you think? If you're already past the getting the check phase, you at least don't get a penalty for not having it at the end of the year. So then we have HIPAA. Now, the guy who invented HIPAA, his name is Bill Braithwaite. He's on our advisory board. He's actually a good friend of mine. And it's very common for Bill and I to come to events like this and be on a panel together because people, and we usually hand out tomatoes in advance because people really like to pelt people talking about HIPAA with, you know, rotten eggs and tomatoes because it seems like HIPAA is the problem, right? And I can go into, you know, HIPAA was actually designed to simplify the problem. HIPAA was, and if you want to talk later about computer security in healthcare or about HIPAA in healthcare, I ran the Cyber Trust organization, a third of we had over 100 million of revenue just organized around helping organizations solve their compliance problems, right? We were very big experts in this sort of space. In the end, the idea of HIPAA was to make it easy, just do a few basic things and do a risk assessment and then do the right thing based on your risk assessment. Because it was so open, it became really hard for people to do. People tend, and organizations tend to like checklists better than open standards. HIPAA is fundamentally a self-certification, and I can go into that later. But it's got, in the end, HIPAA's got different organizations that can sue you or put you on a wall of shame or get you in trouble if you don't follow it. And breaches cause audits and fines, and privacy things and non-compliance causes audits and fines. But one of the things I find is the biggest problem with HIPAA is it requires a business associate agreement if you're going to share data with someone else. And if you just do the math, you know, I'm a scientist, so I tend to do the math. There's 5,000 hospitals in the country. There's 10,000 clinics in the country, just round numbers. If you just take those 15,000 organizations and say, how about if I get organization A able to talk to organization B? To do that, they sign a BAA. So if you wanted that to work between anybody and anybody, all you would need is 7,500 times 7,499 times 7,498 times 7,497 BAAs. That's more business associate agreements than there are grains of sand on the planet Earth. Do you think this is going to happen? It's not possible, right? So obviously we've got to get this problem solved if we're going to get this communication problem solved. Because really you want to be able to share, if that person comes from Bangladesh, you want to get the record back to their doctor in Bangladesh, right? Not only is HIPAA telling you that it's illegal to use text and email and all that, but the Joint Commission says so as well. The Joint Commission says you may not use text, and you must teach your doctors and whatnot, you know, twice a year that's bad and illegal. Permissions is a problem. If you're gonna have that doctor in Florida get access to the records in New York, how do you give permission to the doctor in Florida to have access to the records in New York, but not all the records in New York? And everything is a problem when it comes to changing your EMR. It's expensive and slow is generally a big problem. So I'm just thinking that we ought to fix everything I just said, right? So if you were going to fix everything you just said, the way you'd do this is you'd make, for the clinician, you'd wind up with all kinds of rosy, cool things. On-call experience would be better. If somebody called, well, one cardiologist is calling for another in different practices, this happens every day. How's that second practice supposed to get at the records of the first practice to even figure out what the problem list is? Wouldn't it be nice if you could just do that, right? better time management, better care. If that patient got moved to another practice wrongly, the clerk might be able to send a message to the other place, or the clerk might be able to dip in the EMR in the other place and get the record. Imagine that. Wouldn't that be cool, right? If these things I'm talking about happened, all of that stuff would work. For the family, I mean, why would you bother showing up at an appointment if you didn't need to? For the business, you can wind up with obviously wildly improved efficiency, increased charges, better incentive payments, avoidance of penalties, but really a happier life. Now, there's a bunch of standards that are organized around this pay-for-performance world, ACOs and MIPS and MACRA and on and on and on, HEDA scores and on and on. And everybody who's in the administrative part of your practices knows some of these words, because if you want to get 10, 12% more money out of Medicare, you got to do MIPS, right? If you do MIPS, you're going to get 10 or 12% more money. Well, that's the entire profit margin, right? If you can just get that done, you can get a significant profit margin there. So let me just give you one quick primer on MIPS and communication. MIPS is now the new name for what used to be called PQRS. There's several speeches coming up on this today and tomorrow, so I'm not going to go into the details of this. But there's a new category called improvement activities, and what used to be called meaningful use is now called advancing care, because it's critical to change the name of everything every couple of years just to keep us all completely confused, right? We need to do that, right? I just went through the list of quality measures that had to do with improving, that if you could improve the sharing of medical records or the communication between people in different practices, 50 of the quality measures are that category. I just put one up there, closing the referral loop. In other words, if you get 6 or 7 of these quality measures this year and a few more next year, you get all that green section of getting your extra payment out of Medicare, right? Improved activities, 27 of them have to do with communicating better with other people. Advancing care information, almost all of them. Only one doesn't have to do with communicating better with your patients or with other clinicians. Just requesting and accepting a summary of care. But you know what? The reason these things are on the list is because this is hard to do. This isn't easy. But if you can do a few in each of those cases, you wind up with, at a minimum, 8 or 10 or 12% more money. Right? That's just MIPS. There's many other quality standards that work that way. So if we're going to do something, how do we do it? And what we really want is a system that works no matter what, a system that works with anybody, a system that can work anywhere, a system that doesn't matter whose EMR you have or even whether you've got a fully functioning EMR, something that works even with old, unupdated EMRs, something that works, that gives both economic positive value to the organization or person and makes them feel better, right? Doctor burnout is worse than it has been ever. And most of the blame is being pointed at this did anybody mention that healthcare is complicated? I heard that recently. Some people discovered this. Healthcare is a little bit complicated, and that complication and all these layers of the onion drive people nuts. And the EMR is not making that work better, and that is part of the whole thing. So I've taken that list of 11 dark matter, record sharing, dark ages sort of things, and said, if we could get the solution mapped up with each of those, what might it look like? Strong identity for all users. This is something that isn't as hard as it seems. Oddly enough, nobody's stood up to try and just do it, but we've done it in other countries. We've done it in America for organizations. It turns out that all doctors already have a strong identity because they got all clinicians, all nurses, everybody went through a medical credentialing process in your IPA or in the hospital or both, right? That's a strong identity. All we got to do is hook that to something electronic, and that something can be as simple as a login. It doesn't have to be this complicated, right? Same is true for universal provider access. This notion of strong ID plus a few other things makes for a directory. And wouldn't it be nice if you could just find the doctor in a directory that you want to send a record to or get permission from, and then all of a sudden you could get access to that patient's records, right? Universal patient matching, same sort of thing. That's all about strong identity. Proprietary EMRs requires that somebody who's got that BigSoMoClo cloud working put together some engines that take it from one EMR and reformat it in such a way that it'll fit in the next EMR. Turns out it's not that hard to do. It just somebody needs to stand up and do it. Data format incompatibility, same sort of issue. Provider competitive issues. It turns out if you shift the model from a big hospital is going to share data with a big hospital, and the two CIOs will get together and negotiate it all with their lawyers. If you move that to a person-to-person model, where the patient says, I want my record from that place to give to the other place, or a clinician says, I'd like to, I'm private practice and I'm on staff, right? I just want to get the record out of my EMR into your EMR. That's a personal problem. That's not a big institutional problem. If we think about this as a person-to-person issue instead of an institution-to-organization issue, and we start by solving it on that personal level, this problem can go away. HIPAA privacy and so on, let's leave it up to the cloud vendor to take care of that. If they do a good job, they can get rid of the problems of HIPAA and make strong identity and HIPAA as a service be the thing that glues all of this together. BAAs, the way to solve the BAA, I was a chief medical officer at Verizon, and I ran the HIPAA compliance office for our company, and we had $5 billion of revenue and customers that were in the health space, so we had a ton of HIPAA-related issues. And I said, why don't we just make a universal BAA? And the lawyer said, you can't do that. And I said, sure we can. So we made a BAA that now is possible to click on, just like you click on I agree with every other app on the planet. Well, you know, you're individually taking taking the responsibility for taking care of that patient's data if you're a doctor and it comes to your app. Doctors individually take the responsibility for stuff like that every single day. Why on earth wouldn't I say yes to that? Of course I will, right? If the organization wants to take a bigger responsibility and get rid of the doctor's responsibility, then we have a universal organizational BAA. Why not, right? And if somebody really wants to negotiate and spend a year negotiating BAAs, fine. But you're still going to have to accept the universal ones. And there's some help for some of that in this protocol that's called Direct. On access permissions, if you could organize a way to not only send a record to another doctor, there's a protocol called Direct to allow you to send a record to another doctor. That protocol was required to be part of your EMR and required to be tested as part of your operations in order to get the meaningful use money for MU2. So it does work, right? That protocol isn't being used by anybody. I mean, it's barely used, but it actually is installed everywhere. So imagine if we actually use the thing and leverage it to make it so that we can not only send a record to anybody in the country or in the world, including a patient, but we can also send a permission. So you could send a permission to that doctor in Florida, and that doctor in Florida could now get back to your EMR and just get the one record from the one patient that you share with the doctor in Florida. That's what I call push permissioning. And finally, the long, expensive integration work, nobody wants that. But to the extent that a cloud provider can provide all of the things on this list and make it so that it's a few hours of work to implement this in a tiny practice, 3 or 5 doctors, whatever it is, in that EMR, maybe 3 or 5 hours of work, not 3 or 5 weeks or months, right? Wouldn't it be nice if that works that way? So this is, my team and I are passionate about solving these problems. And that's what I'm in, I've shifted from being a big wig at Verizon to being a startup guy again. And my whole world is around fixing this now. Kevin and Catherine, will you stand up? Catherine just moved in the back somewhere. We're going to be wandering around here, and if you see us, feel free to talk to us, because we're really ready to try and drive this stuff to make it happen. Thank you so much.
That's a fascinating world. Thank you very much. We don't have time for questions, but stay around and explore the possibilities. They're huge. There's steps over on this side.